Hello and welcome everybody to this webinar on long COVID. I'm delighted that you're here to join us, and or if you're watching this on recording. My name is Catherine Hickman. I'm a GP in Bradford and also respiratory lead for Bradford, and I have been involved in the long COVID pathway, both for Leeds and also Bradford, a lot of which was taken from the London pathway, but it really was an excellent pathway and we've adapted it locally. And I hope all of you have had a chance to have a look at it. Before I go any further, it's important to mention that if you are a GP and you're watching this and you maybe have seen a bit of long COVID or feeling a little bit nervous about long COVID, and I absolutely was in that position not long ago, it's important to remember that long COVID is our bread and butter. This is what we have been doing for as long as we have been GPs. We are so used to seeing patients coming in with a multitude of unusual symptoms from head to toe. And we are experts at unpicking as to what will probably be self-limiting and go away, what is maybe more serious and needs to be referred, and what is a urgent red flag. And it is absolutely no different when we're dealing with patients with long COVID. And it can be overwhelming because they are presenting with some strange things, you know, ringing in the left ear, right toe burning, pain in the buttock, and all of these may or may not be related, but it's our job to unpick. And I know I did a presentation a few years ago about our new breathlessness pathway, which is on assist. And I remember saying at the time that actually what is important is to remember that just because we have 10-minute appointments doesn't mean that you have to deal with everything in 10 minutes. And it might be that it takes 4 or 5 appointments for you to properly unpick what is going on with that patient and work out where that patient needs to go. And you might find within that 4 to 5 appointments that the patient is actually better. I think one of the key things about long COVID is a lot of these patients feel very alone and potentially not listened to, or they've been made to feel that they're going mad. And actually our role is to really make them feel that actually they're not going mad and that we are here to listen to them. And actually sometimes that's actually all they need, just to hear that somebody's listening to them and acknowledging that what they're going through is normal, in inverted commas. They will probably get better. We don't know how long. Some people take longer than others, but also there are, you know, a multitude of people across the country and the world who are also suffering from these symptoms. Where we come into this process is obviously we deal with patients with acute COVID, but what we're mainly dealing with at the moment is people who are still suffering from COVID symptoms, and that's up to 12 weeks. And it's within that time frame when they come to see you that it's our job to, you know, make that link, the possibility of it being related to COVID, and to start to work our way through the COVID pathway on assist. And it really is, you know, it was by no means a way of sort of teaching people to suck eggs, and we wanted to make it as simple as possible for you, but also to keep it really systematic, so you could work out, you know, and you know, click on a link that says breathlessness and work through the systematic way of working out what investigations that patient needs, but also making sure that you're doing a thorough history and examination. And as I've said, it's our job to pick out ultimately what is a red flag and may not be related to COVID, and what needs to be referred on urgently. Equally, by working through that process on assist, it's a way of getting some baseline investigations and ruling other things out that may not be related to COVID. If the patient at 12 weeks is still symptomatic, and you have, you know, convinced yourself and the patient that you've done everything that you can based on the assist pathway and your clinical knowledge and expertise, it's at that point that you may want to refer onto the long COVID clinic, or at least have that conversation with the patient is that appropriate for you? Or actually, are there other things where other places or things that you can do to help you to self-care, whether that be exercise or talking to somebody, you know, using your social prescriber, somebody to talk to locally at the surgery, or doing some, you know, online courses. And it's very much that two-way thing, that referring somebody onto a long COVID clinic is not for everybody, but equally that there's a multitude of things out there where we can send patients. There is one caveat. I'm fully aware that when I say to investigate people, you know, pre-COVID, it was sometimes hard to get investigations quickly. It's even harder now. Part of that breathlessness pathway may be getting a spirometry if you feel it's necessary. We know there is a huge backlog of spirometry in primary care, and we take that into consideration when patients are referred onto the long COVID clinic. So I hope that gives you a little bit of overview about our role in primary care as GPs, and it gives me great pleasure to hand over to Jez, who's going to talk to you about the long COVID clinic in Bradford. Thank you very much.
Thank you, Catherine. Hi everyone, thank you for joining us. My name is Jez. I'm the BDC long COVID coordinator, alongside Jenny, previously, now Carol shortly. And I am a physio by background, advanced practitioner trained, and usually work in community services around Airedale area, and then I'll do this role as well. So today, I'm just going to talk a little bit more, sort of elaborating on what Catherine's already said. I'll just share my screen. So hopefully, and then, so hopefully that should have come up okay on your screen. So any questions, feel free to put them in the chat. Any questions after this, we've got some details at the end for how to get in touch with us, and we can definitely get back in touch with you straight away. One thing we are really keen is to make sure that we work with everyone within the patch, so whether that be other services, but particularly the GPs as well. We'll go through the data in a minute, but pretty much all the patients that we're getting are nearly always from GPs. So that dialogue is really useful to us. It really helps us to understand what GPs are wanting from us when we see the patients, but also that we're more than happy to be sort of feed that back as well in terms of what we found. If there's anything else we can help with, if you feel that as a patient that's managing really well, but you just want to get in touch, by all means send us an email, and we're more than happy to get in touch and have a chat as well. So we're sort of here to work with you, and for you to support us and support you as well. So moving on to the first slide. So we're going to talk a little bit about the data, a little bit about what we're seeing, and then we'll talk a little bit more about long COVID as well. So in terms of the data itself, we've currently got 331 patients on the caseload. We have been running the caseload since July was when we started accepting referrals. We're getting about 10 to 15 a week on average at the moment. It shot up at the start, but it seems to have settled around that number now. In terms of the demographic that we're seeing, it's in some parts we match perfectly the national picture. So we're about 70% female that we're getting through, which does sort of fit with around 65-70% that I think is the national average at the moment. In terms of age groups, we're generally seeing mainly people of working age, and that's probably one of the biggest factors for a lot of these patients as well, is that because they are working age, and because obviously finance, particularly at the moment, is so important, there's so many other stresses that have been put into the situation, and other priorities in terms of getting back to work, and we're finding that that's quite commonly affecting the work-life balance. All energy that they do have, they're trying to put into work to manage that side, and then that's causing other problems as well within the social side. In terms of the indices of deprivation, we're generally seeing mainly within the lower numbers, so the 1 and 2, 3 area, which I think to start with, that wasn't being seen across the country, but I think that has increased a little bit more recently. In terms of the map on the left corner, it's quite small, but essentially the cluster is around Bradford. And as we move further out, we've got up towards sort of Skipton, Grassington, and Settle area, where there's a lot less. So most of our referrals are coming from the Bradford area. In terms of ethnicity, we've got about a 55% white British population, and a large population of Asian or Asian British in comparison to the rest of the country, which will probably fit with our local ethnic groups as well. So that's generally what we've seen so far. We've just employed 14 staff members who are all going to be starting in January. So far we've been doing the assessment arm of the pathway, and the rehabilitation arm will all be up and running from January, which is really exciting. So in terms of referrals, in terms of the pathway itself, so a bit through pretty much what Catherine's already said really, is patient is normally within their own home, within their own environment when they start to come forward and need that help. So when they get in touch with the GP, as Catherine's always mentioned, it's going through those normal assessments. Excuse me. It's making sure that we look for the normal red flags that we would look for. COVID's made everything extremely different at the moment, and it's sort of put another condition in there that we to think about as well as everything else. It means we really need to focus on those conditions that we already assess day to day, and particularly those red flags to make sure there's nothing that needs managing urgently with these patients. So if that's all been covered, there's other alternative diagnosis, then brilliant, just follow the normal pathways for that. But if there isn't, then is there any sort of self-management, as Catherine's always mentioned, at home that they could be doing? We do generally accept referrals 12 weeks onwards, but we will take referrals earlier than that. There is a waiting list, so by the time we do take them, it will be around that 12-week stage. But if you did want to refer someone in who you feel has been doing all the self-management, you've been supporting them brilliantly, and there's nothing else that can be done at that point, feel free to either get in touch or refer at that point. That's fine. If the patient's improving, then brilliant, just continue with the self-management. But if they're not, then that's the point when you can refer through to us. So as Catherine said, we tried to make this really simple from a referral point of view, just because we didn't need to have all the information in the world from you guys. It didn't need to take all your time to do that either. So we tried to make it really simple, a couple of click boxes, and it'll send through. The referral form isn't telling you how to diagnose and assess and manage these patients. It's just there to give you a little thought to think, have I tried to manage fatigue? Yes, I have. Have I asked about that? Yes, I have. It's just a little point and nothing else. Once it comes to us, we'll work with the patient, we'll assess the patient in full, but it just gives a little bit more support, again, just trying to make sure I've gone through the things. One question that I put at the bottom was, as a referrer, are there any symptoms or functional deficits that you are continuing to manage within primary care and do not require further input into this point? So this is something that me and Catherine had talked about quite a lot at the start, about how we weren't necessarily trying to take patients and remove them out of primary care. This is the bread and butter for primary care, but there are certain aspects that might be managing quite well, but there's other areas that aren't improving. So if there's points in there, feel free to sort of put a bit more detail into there. Generally, the answer we're getting is no, please support them with everything, which is fine, and we understand that. But we do want to work as a bit of a team with this as well. So feel free to put anything in there if there's something you're working with and you'd rather continue with that. We know about that then, and we can get back in touch with you and work with that together. So that's all on GP Assist. In terms of this is the draft version of the long COVID assessment and rehabilitation service. So without trying to go through in too much detail, hopefully you can see my cursor, but essentially when the patient is referred in, they're referred into the assessment and coordination side of the pathway. Once they get referred in, we have an associate coordinator who will contact the patient, they'll register them, and they'll put them onto the appropriate arm of the pathway. At this point, they'll complete an app, which is something that's been developed locally, and then we've worked with Leeds, and Leeds have pushed it through to be now the first worldwide outcome measure for long COVID. So we've got that with an app, so the patient can complete that every 6 weeks whilst on the pathway. So they'll complete that. That gives them the initial assessment that we can see. So when we get in touch with them, we've got an idea of how they're managing in different areas. We'll offer them the 7-week primary care wellbeing course. So at the moment, this is something that we're offering at the rehab side, but once we start to get people through, we'll move this to the earlier stage. And then we've got Shared Harmonies as well, which is a local VCS group, which are offering support for breathlessness and anxiety. And it's a online course that they can do, which patients can support at that point. So we try and get that in right at the start to work with these patients. Once they've had the coordinator assessments, that's done by either myself or done by Carol. We spend about anything from generally about 45 minutes with the patient, either virtually or on the telephone, going through all our assessment, making sure that we know all the different things about them, what triggers there might be, what symptoms they've had when they started, when they were diagnosed with COVID, or where the history of COVID has come from, how they've been then, and how they're out to now. So it's a really in-depth conversation. As Catherine was saying, one of the biggest things that these patients are feeding back to us is that they like the fact they feel they've been listened to. And I don't think that's necessarily negative in primary care. We're spending 45 minutes with these patients. We know that's not always available, or very rarely available in primary care in terms of in one session. But as Catherine was saying, it can be broken down as well. And getting that rapport with that patient is really important to understand. There's a lot of times if you go through the questions, they won't necessarily elaborate on things that have happened in the past. But when you actually really go into it and through the record, there's often something that might be a trigger there that will come into a bit later on as well. So we'll either keep them within our service, within the assessment side. If they're managing really well, we're going to do some more self-management work. Then we'll just see how they're doing in 6 weeks' time at that point, and then we can work on from there. It might be that they're doing brilliantly and they don't need any more than what we've given them. So we'll discharge them back to the primary care at that point. And then it might be that they get referred into the therapy arm. So this is what's all going to be up and running from January. So we've had the virtual MBT running for quite some time. We're really lucky to be supported by a respiratory consultant, cardiology consultant, rehabilitation consultant, and then there's myself as the physio, and then my colleague Jenny, who was dietitian within there. And then there's also psychologists supporting to that as well. So we get a really good idea of, again, looking for any red flags that we've found through the assessment point. Is there anything else we need to go on for further assessment? And if there is, then we might refer back to the GP at that point to ask, could we complete this assessment just to add in fullness? Or it might be just something that we need to work with the patient on. The therapy-led objective clinic is something that we are setting up for January, which will be where we do all the objective assessments within one place, as well as working on some peer support. I can go through this a lot more detail later in another day, but just to give you an idea of what's there, it might be that they get a home visit at that point as well. Once they come into the rehab team, we've got physiotherapy, occupational therapists, speech and language therapy, dietetics. We're getting some psychology support, some mental health nurse support, psychology assistants and therapy assistants. So it's a really good, strong MDT with an equal focus on both mental health and physical, which we think is really key within this patient group. A couple of things in terms of the types of patients that we're seeing. So we're generally seeing that as a respiratory cluster. So generally, people who've maybe been more on ICU initially, or had more problems at that point, may have more from a cough point of view, breathlessness point of view, and need some more management down that. So often breathing pattern disorder is something that we're really trying to focus on with these patients. But as you know, that's not a quick fix. Then there's the tiredness cluster. So fatigue, cognition, brain fog, lack of sleep. And sleep is one of the biggest things that if we can get that right, that gives them a real opportunity to improve going forward. And again, that's something that sleep hygiene you'll have been working on with all your patients for many years. Vocational support, as I've already mentioned, really important for these patients to get them back into work, but also to do it within a safe way. A lot of employers don't know what long COVID is, so we give them some information on to give to their employer as well to try and support them back in. So rather than doing a 2-week return to practice and being back in to full time in 2 weeks, it's just not long enough for this patient group in most patients. So we look at trying to give a 2-week space before trying to increase activity with patients or increase the workload. And financial support as well, going through that side of things. If they are off work, are they managing okay from that aspect? Goal setting, really looking at goals with these patients and focus on that side of things. Working out if there's anything else they need from a home point of view to manage at home, but also then with most of these patients, it's actually getting out of the house and then that next step, once you're getting back into the community that they need the support with. And dysautonomia is something that is really come to the fore with this. So people who are getting dizziness, headaches, sweats, problems with POTS, so in terms of the heart rate and the blood pressure. So we're trying to focus on that, and we're going to try and get some really good information pieces for the patients to understand that as well. But again, if that's something you want more support on in the future, then we're more than happy to support. So looking at rehab-wise, virtual, face-to-face, group sessions 1-to-1, and education-wise, group, face-to-face and virtual. So a really wide mix. All these patients, as I say, nearly always working age. They are generally been very good with using telephones, virtual methods, group sessions. So we're really trying to focus on that going forward. And from the mental health point, so we've got mental health across the whole pathway, but just to give a little bit of an idea, this isn't your normal mental health pyramid in terms of escalation-wise, but more from a point of view of complexity. So we've got My Wellbeing College that we're using with a lot of our patients, the access that we'll have within the long COVID pathway to mental health, and then also primary care wellbeing that we're working very closely with too. And then the volunteer and community services that we're really going to try and increase once we start to get more of this rehab arm in place. So just if you ever did have a patient who had long COVID, you sent them into our service and they've come back to see you, they will have completed one of these, the C19YRS. Most are completing on an app on the phone, so they'll probably have that with them. We do put it on System 1 also, so it is there in the on System 1 for you to see the outcomes as well. But it gives you some really nice graphs in terms of what they were like pre-COVID, so normally the first stage, but also what they've been like since then, and then every 6 weeks going on. So it gives you a really good idea of where to focus on as well. And this has won a nice little award as well and gets good feedback. So in terms of our assessment, just to give you a quick overview, this is what the form we use on System 1. We work our way through. The first question is always tell me about your COVID journey. When did it start? What happened at that point? What's happened since, and where are we now? And it normally can be a 5-minute response, or it can be a 25-minute response from the patient. But it generally gives us a really good idea of what they're focusing on, what matters to them, and what their key issues are. So we'll go through all the, once they've done that, we'll go through all the symptoms, talk about the social circumstances and the financial and work side as well, and often look for all the investigations as well to see what they've had previously and what they need going forward. So in terms of just a couple of slides, just to get us thinking about things more than anything else. So there's 2 studies that were done. One was done by Jones et al. That was more Cambridge based, and one done by Thompson et al. That was more London based. And the Thompson one was looking at a number of studies that had been done already at that point. So this is more just to think about the data. So we're starting to learn about long COVID, but we still don't know a lot about long COVID. There's a really good piece of work out there. Leeds are doing massive study at the moment to look at this going forwards. But in terms of the differences that we're seeing, so on the left-hand side, you've got the Jones side, which suggested that older age, female, frailty, and visits to A&E were key for these patients, yet quite differently. For the Thompson side, yes, female, but we've got poor pre-pandemic mental health, general health, asthmatic, and overweight or obese. And it's quite a different patient group, that are quite a different group to look at. We've only 0.8% to 5.2% have been admitted to hospital. So just to start to think about the data that we are seeing is very helpful, but it's also something to consider as well. So I think from our patient group, the right-hand side, so the Thompson group is pretty much fitting exactly what we're seeing for the majority of our patients. So a female, generally having some poor pandemic mental health, whether that's a recent loss of a family member or something that they've been under psychology before or under mental health services. General health as well, and asthmatic, particularly people who have had childhood asthmatic but nothing since, are reporting that they're getting these exacerbations of that at this point or increasing symptoms. And overweight and obese is also in there as well. So just to continue on that front, so this is the first study. And again, just to go back to, it gives a little bit of an idea of when we're trying to manage patients, what we're trying to manage. So they had 3,000 patients, 2,200 of these, so 70% of the cohort had been self-diagnosed but not test confirmed. And of this, it was found that only 3.6% had long COVID. So the number that we generally see is 10%, which is what the average was for this, which came out quite a few months ago, or maybe a year ago now. The second arm is the clinically diagnosed but not test confirmed. So for that, you'd have had to see a medical professional, you'd have probably seen a doctor, you'd probably seen your GP, or you've been to A&E. Because of the pandemic, it either wasn't appropriate at that time, there weren't the tests at that time, or it wasn't felt it was needed. And from those, there's 32% of patients are seen as long COVID, which is quite a high number. So 1/3 of all patients that I've seen are suggested to have long COVID. The difficulty is that if you had diagnosed COVID at the time, you will have diagnosed off the basis of temperature, cough, breathing problems, all the things that you would see with long COVID now. So yes, 30% sounds very high, but also you've essentially said they've already got all those symptoms. So you've sort of, that long COVID was probably set up a little bit from that aspect as well. And then you've got your test confirmed positive. So these are patients who've had a test, it's come back positive, and from that there's 20%, so 1 in 5 patients. So it's just to start to think about those different arms. So you've got 3.6% of people have self-diagnosed, which suggests that potentially not all have been COVID. We know at this moment that there's lots of infections going on at the moment, and tests are coming back negative for a lot of people, yet they're having symptoms that a year and a half ago when we didn't have these tests, you'd have put them down as COVID. So it's just trying to not be skeptical one way or the other, but just to accept that there is possibilities that certain things will lead to certain diagnosis. And that's quite key in terms of the, so my screen's about to turn off. In terms of the diagnosis itself. So when you are coding long COVID, that's obviously on their system going forward. That can make a massive difference financially for some people who have been off work, who can't get into work at the moment because of this diagnosis, and that's what they really need. But also having that idea that they've been told they've got long COVID when they do come to us. For the people that we do feel that when we've assessed them that they don't have long COVID, it's also quite a difficult thing for them to come back from that, because they've had this diagnosis. It's the thing that's in the news. They've told all their friends for the last sort of 6 weeks before they've come to see us. And then we say, no, it's not that. And it's quite a difficult thing as a patient to be told you've not got what you've already been told by someone else. So it's just being aware of that diagnosis and aware of that conversation at that point. It is needed for people in terms of to get the finances that they need at the moment to manage. But equally, it can have a negative side as well. So just something to think about. So just progressing on from that. So the diagnosis of long COVID, this is the end of the definition. So symptoms and abnormalities must not be attributable to other causes. And again, this goes back to what Catherine was saying in terms of there's so many other conditions out there as well that we would manage day to day. And it's something else that long COVID. So when I did my advanced practice course, we got told from more of a medical point of view, which I'm guessing you've been told a long time ago, but if you hear hooves, don't look for zebras, which I always thought was quite an interesting thing. From a physio point of view, I've always thought there's always these small conditions that it could be, so you've got to try and rule out everything. But more from the medical point of view, it's often the other way around and looking what is it likely to be, what do we need to look for red flags in everything else. And long COVID is new, so it's sort of, we don't really know where that fits on that zebra to horse sort of idea yet. And I think that's quite important. So yes, if someone comes in and they say they've had COVID and they've got symptoms of long COVID, it might be the obvious thing to look for, but it doesn't necessarily mean it's not another post-viral infection. It doesn't necessarily mean it's not something else that's going on, newly diagnosed asthma or something else. So it's just to start to think about that a little bit more. And persistent symptoms is something that we're seeing. So people who've had persistent symptoms pre-COVID and have continued on, we're seeing quite a bit of that. Recent traumas such as loss of family members, particularly in this case at the moment, it's been more than normal. And yeah, past medical history as well. When you really delve back into their past medical histories, often there are little triggers here and there that might be the cause of their breathlessness or might have led to COVID affecting that area, which is really useful to manage and supporting these patients. Equality-wise, again, with the evidence, we don't really know for definite what numbers we should be getting of different ethnicities, different age groups, different financial situations, because the data isn't there yet, and we'll know in a few years' time. But at the moment, we're seeing a lot of people in the lower deprived areas of living. We're seeing a lot of people from all ethnicities, about 50% white British, we've already said. So yeah, it's just being alert and aware of that this is affecting everyone at the moment, and we don't definitely know yet what we should be getting numbers wise of different areas. Case study wise, just to give you a couple of quick case studies. So case study one, so we've got had a patient who was a lawyer, who was definitely a high achiever, used to being extremely active from a running group point of view, from a cycling group point of view, from a family point of view, and since COVID has just lost all of that from an activity point of view outside, has returned to work and he's started to do really well from that aspect, but that's all the energy going into that side. And that's quite a common thing that we're seeing with a lot of patients. That fatigue support is really important with this group. So whether that's managing fatigue, whether that's how to progress going forwards, whether that's doing an activity diary, but we're really getting an idea of what you normally do, accepting now as the new sort of level, but not the new normal, and aiming back towards where you were rather than trying to get straight back to it has been really key for a lot of these patients. So even increasing activity by 5 minutes at a time rather than doing an extra hour once a week that we might have done previously. Case study two wise, going back to case study one, also the mental health side of that as well. So that loss of social role, so that's massive as well. So being able to accept that and work with that going forwards, and being able to accept as a high achiever, often it's quite difficult to do things like meditation, relaxation things, because you would get your relaxation through doing activity. So if you don't have the energy to do that, that's a really difficult cycle to work through. But it doesn't mean it's not possible to get there. It's just going to take longer. So that's again if someone's on a way to try and work with something, it's not necessarily that hasn't worked straight away. It's just going to take more time with a lot of these patients. Second case of this, a patient who had a business owner, lots of traveling. So we're seeing shift patterns of massive. So people who work nights, people who work long hours, certain days and not the other days. The body gets a real sort of peak and trough system. So boom and bust, which is really not good for this patient group to work with going forward. So the more you can level out and the more you can level your day-to-day and your week or your month, whatever it might be, the more chance you've got of your body having to not get used to this idea of being constantly up and down. And on good days, not using all your energy, and on bad days, not using or using some energy. But again, this is something that you'll have told all your patients for years and years and years. It's just this patient group also is really key with that side. So for this guy, for instance, it was he would drive all the way down south for the whole week, would work long hours for the week, would get home, and then would spend the whole weekend in bed because that was their sort of time when they had time to rest. And that's really difficult from a social point of view, family point of view. But work was just what he had to do. So we started to sort of discuss that a bit more and work onto that side of things to give him an opportunity going forwards. A couple of patients who we weren't as convinced from a long COVID point of view. So one who was a baker, worked in a bakery for all his life, I think about 30 odd years. He had started so it was diagnosed with COVID 4 months later, but pre to that had been started with symptoms that had been sent a peak flow test and was advised to do that, was sent an inhaler, and was diagnosed with early with new asthma just before having COVID. At that point, they weren't able to go to work because of the fact of the breathlessness and everything else. So they were actually missing work more likely not because of pre-COVID as well as when the COVID came around. They then started getting a lot of knee pains, but they've been on the feet for 30 odd years working, whereas now they were sat at home unable to do that. So you're going to get knee pains from that. It's natural to have that side. So they did have a number of symptoms that were sort of spread around the body. But when you sort of broke it down, there were one clear reason why they had all the other symptoms really, which wasn't necessarily COVID. So again, just working through that patient and working through the symptoms with them is really important. Another patient who had bipolar since a very young age. And when we spoke to them, lots of different symptoms, all fit with COVID, but the symptoms all started pre-COVID times, quite a bit before. So it was probably likely that this patient had had pneumonia. It was probably likely they'd had post-viral issues, but it just, for this patient, wasn't COVID. They'd had tests post that all negative, an antibody study test as well. And with this patient, when we talked through everything, they'd said that they'd finished work, but they were still volunteering pretty much 9 to 5, 4 days a week, which they didn't class as work. And when we started to talk about all that, we did get back in touch with them 6 weeks later, and they'd gone back into a new job. They were taking that other job back up again. They were managing really well. And just again, that activity management. So what we're offering these patients is the right thing for those patients too. But for that patient, it just wasn't long COVID. That was their driver. So yeah, happy to discuss any patients that you've got. So finally for me, this was a slide I did a little while ago, but thought it was quite interesting. So what pathology are all these symptoms of? So fever, sore throat, rash, fatigue, joint and muscle pain, diarrhea, night sweats and swollen glands. So they could all be linked to long COVID. With these ones, it was HIV that we're looking at the time, so it would also mimic a lot of the similar things. But there's probably another 20 pathologies that you could all send in, which would all match these symptoms. So again, it's just thinking, what else could it be, and just making sure we're not jumping straight to long COVID, just because that's the main sort of theme at the moment. But yeah, so yeah, discussion point. So just welcome Catherine back if that's okay. But yeah, any thoughts from a GP point of view? Anything that you feel would be good to discuss from there?
Firstly, thank you, Jez. That was brilliant. And actually, you know what, it makes me think that actually, so often as a GP, when we refer patients into a service, we have absolutely no idea what's going to happen to that patient. So it's difficult to sort of always portray that to patients. I think particularly for me as a respiratory interested clinician, pulmonary rehab, which is not dissimilar to things that you're doing, and actually having that knowledge of what is happening to that patient makes it easier for me to sell it to patients as well. So that was great. I suppose one question for me is what would make it helpful for you? What can we do as GPs to help you make that as seamless as possible for you and the patient.
Yeah, so I think the main thing at the moment, we've got a number of referrals. So as I say, we've had 310 referrals. The rehabilitation side is all up and coming. But that sort of acceptance that we would love to be able to offer them something within the first week. We'll get in touch with them straight away. They'll start to have input. They will start to have an assessment through the app. They will start to have things like the shared harmonies, which would be brilliant for them to access. So they'll start to have input of the rehabilitation side of things immediately as soon as they get referred in. That assessment arm will then develop as we go on. But the fact that they've been referred in to a long COVID service is that they've been referred in for assessment to start with. So assessment for, is this long COVID? And then for the rest of it, depending on where we find from there, rather than being referred into a service to be treating your long COVID at that point. There are some, as we say, that are clearly long COVID, but it just sometimes will make it a little bit easier just from that point of view. And I think the other side is just conversation. If there's anyone that you feel or need more information on, just send us a task, that's absolutely fine, or send us an email. If there's anyone you want to discuss that you want to keep within your service to start with, or more within primary care to start with, that's absolutely fine as well. So yeah, just conversation.
No, that's great. And this is something that we've talked about as well, that if a GP refers in and they've put nada on the referral form, it's not that they will be rejected and sent back. You will open that dialogue and say, actually, and they may not be aware of that pathway on assist, and so it's about directing them to the pathway and actually just working through the things, get some baseline investigations, make sure there's nothing else going on, and then refer and allowing that conversation to happen between us and you is, I mean, I think it's really helpful. And again, it would help so many so many other clinics that we refer into. If they get rejected, you almost have to go right back to the beginning, whereas actually having that open dialogue and saying, can you do this first, and then refer, and then we'll take them on.
Yeah, definitely. I think from when we get everything set up, there'll be clinics that have been run within the Craven area, within the Airedale area, within the Bradford area. If anyone wanted to come and spend time with any of them, or if they want to jump on the virtual one, there's going to be all sorts that's out there. So yeah, just get in touch and we're more than happy to share work together.
Fantastic. And I know something else that we've discussed is that possibility of almost like doing some group sessions with patients as well, almost like before they get into the service. I know some GPs across the country have started running these, especially when there's a backlog as well. Almost like it allows patients to talk to each other and sort of acknowledge that actually they're not going mad. And I know there's been quite a lot of success there as well. So yeah. So the therapy-led objective clinic that we're going to be running will hopefully bring 5 to 10 patients together at one time to support that, almost like a coffee morning style way to get that peer support, and then assessing them individually outside of that. So yeah, definitely peer support is good for these patients. It's key, isn't it? And I mean, and in conversations I've been having earlier today about the pulmonary rehab service, when patients have been offered online services, now the majority want to actually see people, they want to talk to people, they want to maybe not touch people, but they just, because I think loneliness is such a, we knew it was a problem anyway, but actually it's far more of a problem now. And actually these patients probably are feeling very isolated, maybe out of work, and have not been having even the most basic of human connection. And actually it's so important for them to be heard and listened to, and for us to take that time. And if it takes 5 appointments, so be it. And then if they get to you, then they do get that longer time to speak. So it's really key.
Yeah, definitely agree with that. I think there's a lot of people that like to socialize, a lot of people that like to have their own time to themselves. But these are generally people that are working age, that are normally out and about, that are normally not used to doing anything of the sort, and they're normally used to being out and never even been in the house half the time. So to being sort of locked away in the house, unable to get out from a physical point of view, from a mental health point of view, it's just been really difficult for these patients.
Yeah, crippling, awful, and it's almost trying to unpiece that, unpick everything, because I sometimes try not to make that distinction between mental and physical health, in the sense that if you're physically unwell, you're mentally unwell, and vice versa. But yeah, it has a massive impact. So yeah, it's a really key service. So yeah,
brilliant. Thank you very much.
Not at all. Have we got any questions, Kath?
Hi, Catherine. Thank you.
Hello.
And thanks, Jess, for doing that. Really interesting. I think probably you have picked up the few questions that we did receive in. And I think the key one was around what can GPs look out for and how can this support the service. And the other one was around generally the themes that you were finding patients coming in with, Jez, you know, around the malaise and the different symptoms that you're experiencing, and whether there's anything, you know, are there some common threads that are going through that you're finding with these patients, I guess. But that, I think you've managed to cover everything off in your presentations. Thank you.
And, you know, if people are watching this as a recording, it's absolutely fine. I'm sure you're the same, Jez, if you do have further questions, to get in touch with us and ask. And, you know, if anybody needs signposting to the pathway on Assist, we're more than happy to answer those questions.
Thanks, both.
I'll just share the last slide because that's got the details of how to contact. I'll get told off, but don't press this. There you go.
We will.
If anyone's just getting in touch.
Yeah, thank you, Jez. We will send everything out in the bulletin and on the comms and everything, so that anybody who wishes to watch it in their own time, they're very welcome to do. But thank you for that. Thank you very much, Jez. Thank you, Catherine, for that. It's been really helpful, really interesting. Anything from anybody else before we close the session? Nope. Okay, that's lovely. Thank you both very much, and thanks, Kate, for setting the session up as well. Thank you. Thank you. Bye-bye.